Good afternoon, everyone, and welcome to the Ambulatory Care PRN webinar. We are happy to welcome Drs. Jelena Lewis and Amy Thompson to provide a webinar and roundtable program for building and sustaining services in value-based care. Dr. Jelena Lewis is an assistant professor of pharmacy practice at Chapman University School of Pharmacy and director of residency and fellowship programs. Her clinical practice site is at Providence Medical Foundation in Tustin, California, where she provides value-based care through chronic disease management and population health management. We also have Dr. Amy Thompson, who is a clinical associate professor of pharmacy at the University of Michigan College of Pharmacy and director of clinical ambulatory care pharmacy practice within the University of Michigan Medical Group. Her clinical practice site is within primary care, and she provides chronic disease state management for patients. So we are very excited to have our two speakers who will lead us through this program. Just for some housekeeping, we will be recording this session today. We also will be sharing this session on the Ambulatory Care PRN's YouTube who will offer their guidance in our roundtable sessions as they come up. So with that, I'm going to go ahead and turn it over to our speakers to kick us off. Thanks for being here, guys.
Thank you so much, Megan, for having us. Thank you, everyone, for listening in today. We're really excited to be here. As Megan mentioned, myself and Amy will do a webinar today on value-based care and how pharmacists can contribute to the delivery of value-based care. Our objectives for today are to describe the delivery of value-based care and its role in outpatient settings, and to describe the methods to implement and measure pharmacist-delivered value-based care. We hope to meet the first two objectives through a short presentation, and then what we will do is follow this by some breakout sessions where you can discuss and exchange ideas about how some of you on this webinar today may have implemented value-based care at your respective practice sites and how you track interventions and ROIs. And finally, we're going to close off by giving another short presentation and discuss emerging opportunities for pharmacists in the delivery of value-based care. And again, after Amy and I provide you with our thoughts on this, we will follow this by some breakout sessions where you can all discuss more about the opportunities for pharmacists in the delivery of value-based care. So let's start with a brief overview of value-based care. So value-based care is really a path to achieving the goals of Triple Aim, which many of you on this call have probably heard of. The idea of Triple Aim was introduced in 2008. It's an approach to optimizing health system performance. And it proposes that healthcare institutions should simultaneously pursue three dimensions of performance. Those three dimensions are going to be improving the health of populations, enhancing the patient experience of care, and then reducing the per capita cost of healthcare. And in order to achieve the Triple Aim, healthcare models had to shift from providing primarily acute reactionary care to a good balance of acute, chronic, and preventative care through the delivery of value-based care. And a major part of this is actually population health management, which we're going to talk about in just a little bit. In 2014, it was suggested that a fourth aim be added. So that's actually in the purple portion of this pie. And it focuses on improving work-life balance of healthcare providers. And this is actually a hot topic today, and it has been for many, many years. So expansion of pharmacist roles can help support many aspects of the quadruple aim, including the one of helping improve work-life balance of physicians and decreasing physician burnout. And so what pharmacists can do about this is, under various collaborative practice models, we can assume the responsibility of chronic care management, preventative care, in order to increase the efficiency of the care team and support value-based care. And through doing all this, we can actually have a big clinical impact. So rewind about 5 to 10 years ago, most healthcare billing and payment was based on the fee-for-service model, and that rewarded the quantity of visits completed. So because of this, sick care was a priority, and patients would receive primarily sick care when they saw a physician in the office. This led to fragmented care, and what this really means is that preventative healthcare interventions were really not being done. Really, we were so focused on sick care that we forgot about, hey, did you receive a flu shot, or are you due for a PAP or a colonoscopy or something like that? So this led to fragmentation in the system, and this has been identified for quite some time now. In the last few years, we've seen actually a large switch to value-based payment models because of this fragmented care. So over the last decade or so, maybe a little less than a decade, there has been a shift in focus to value-based payment models that are heavily focused on the delivery of high-quality patient-centered care. And in these models, sick care is still necessary, so sick care is still provided, but incorporation of population health management and team-based care is utilized in order to improve the quality of care that is being provided. And the focus has shifted away from quantity of services provided to provide this quality of care or high quality of care, patient-centered care that results in a decrease in the total cost of care. Most value-based payment models will require the use of high-functioning healthcare teams because this takes significant oversight and effort to achieve. So really with value-based care, we're shifting away from fee-for-service. Providers and healthcare organizations are paid based on patient health outcomes and ability to control costs. Which means a healthier panel of patients the doctor has, the higher the reimbursement. And an example of that is the more patients the doctor has on their panel who have an A1C under 8% or even 7% or blood pressure under 140/90, the better the outcomes will be in the long term, meaning less complications, less ER visits, less urgent care visits, and that will lead to a decrease in total cost of care eventually. This model is different from fee-for-service, where providers are paid based on the amount or volume of healthcare services they deliver. Fee-for-service is actually a system of health insurance payment in which a doctor or another healthcare provider is paid a fee for each particular service rendered. So this gets us to accountable care organizations and patient-centered medical homes. And I'm sure that many of you on this call are familiar with these concepts or these terms. And so in 2015, in April, I believe, Congress signed the Medicare Access and CHIP Reauthorization Act of 2015, and it is known as MACRA. They signed this into law, and this shifted payment from fee-for-service toward primarily value-based payment models. And one of MACRA's model tracks are alternative payment models, or APMs. And under this umbrella of APMs are ACOs, or accountable care organizations. So ACOs are a groups of doctors, hospitals, or other healthcare providers who come together voluntarily to give coordinated high quality care to patients that they serve. Coordinated care helps ensure that patients, especially the chronically ill patients, get the right care at the right time, with the goal of avoiding unnecessary duplication of services and preventing medical errors. So if an ACO succeeds at this in both delivering the high quality care and spending healthcare dollars more wisely, it will share in the savings it achieves. And there are many different types of ACOs, which we unfortunately don't have time to get into today, but they're mostly based on how much financial risk an organization is willing to take on. So While an ACO is more of a reimbursement model, PCMH, or patient-centered medical home, is really a care delivery model. It is a team-based approach to comprehensive primary care coordinated by a PCP. And this model is thought to improve quality and safety. An example of this could be a physician utilizing a pharmacist for diabetes management for one patient, and then a case manager or social worker to help with transportation for that same patient to and from appointments, a behavioral therapist for maybe some mental health issues, and a registered nurse for a patient to come in for a blood pressure check. So this can all be utilization of resources within a PCMH for one patient. So how do pharmacists impact value-based care? Pharmacists can help a lot with the quality metrics when it comes to value-based care. And this is usually achieved through population health management and providing direct patient care services. So population health management is really a descriptor used to describe the health system, practice, provider level management of patient populations with the goal of improving health outcomes, preventing complications, and decreasing costs. And it is becoming more and more important as we move away from reactionary care toward proactive management. So population health really is identifying and closing gaps in care. So for example, A1C above 8% or 9%, depending on payer, statin initiation, blood pressure above 140/90, patients who may need nephropathy screening or an ACE or an ARB are all some of the gaps in care that we can help close by getting these patients to an A1C under 8 or a blood pressure under 140/90, or making sure that nephropathy screenings have been done. It does involve utilization of best practices for prescribing and utilizing evidence-based guidelines. Formulary management also plays a role. So this can be something as simple as switching a brand name med to a generic, or switching to a lower cost alternative medication, and then improving medication and health quality metrics overall. Another way the pharmacist can impact value-based care is by providing patient care services. So they can manage medication therapy, thereby helping with medication adherence. They can provide chronic disease management, like diabetes management, hypertension, asthma, Hep C. There's so many different ways to provide chronic care management. Then there is care transition, so maybe transitional care management, which deals with post-discharge med recs. And then we can be involved with prevention and wellness, so we could perform annual wellness visits and drug therapy consultations. Keep in mind, in order to achieve all this, teamwork is imperative. So together, everyone achieves more. So high-performing healthcare teams are going to be able to achieve much, much more than any individual provider on their own. So working with not only primary care providers, but working with dietitians, nurses, medical assistants, social workers, case managers is really key. An example of this, one of the best examples I can think of at this moment in time could be to work with a dietitian to optimize dietary plans for patients, or asking quality department at your organization to identify patients who have not had a diabetes lab done in over a year. Or maybe talking with case managers and asking them to let pharmacists know if they come across a patient who has many meds on their list, or who may need some extra help clarifying what they're taking and going through their medication list. So there's so many variations of this, actually. We can go on and on, but I'll just stop here. Now let's talk about implementation and measuring outcomes in value-based care. And the way that Amy and I are going to do this is by discussing our respective clinical practice sites. So my clinical practice site is within Providence Medical Foundation, which is a part of a larger health system, Providence, that spans within several states. I'm located in Southern California in Tustin, which is next to Irvine. And in Southern California, we actually have many medical groups within Providence Medical Foundation. We also have many clinical pharmacists embedded in almost every medical group within the Southern California location of Providence. Some of our pharmacists also support Northern California, but this is 100% remote. Our department is fairly young. We started back in 2017 with just one clinical pharmacist, and fast forward to now, we have more than 10 pharmacists and more than 3 pharmacy technicians. The pharmacy technicians help us with scheduling, workflows, patient calls, etc. We also have pharmacists who are hired by Providence 100%. We also have a 50-50 split. Pharmacists who are funded 50% by Providence and then 50% by Chapman University School of Pharmacy. And then some of our faculty are faculty and residents, and they're 100% supported by the university. We are an ACO, so we do work closely in team-based care models with PCPs, nurse practitioners, PAs, and other healthcare providers. We have a CareRx pharmacy department, and our pharmacists work in team-based care models. They provide diabetes, hypertension, dyslipidemia, polypharmacy, and annual wellness visits at their sites. Our pharmacists are in clinic anywhere from 1 to 3 days a week, and post-COVID, most of our patient appointments are still over Zoom or telephonic. Prior to COVID, we did almost 100% only in-office visits. We do have a pharmacist dedicated to transitional care management to help us meet the quality metric for 30-day readmissions. And most of our pharmacists, including our managed care pharmacists, are heavily involved in population health management, where we aim to close those gaps by identifying patients from care gap lists to achieve payer goals and to help with disease management, therapeutic interchange, appropriate medication use, and increased medication adherence. We do utilize AP and API students and our pharmacy residents to help us with population health management. Most recently, we have also developed a population health elective at Chapman University, which enlists students to help with adherence calls and 30 to 90-day conversions. These are these are basically it's just an example of some of the primary pharmacy measures that we focus on when we see patients in clinic and also through population health management. So we focus on that diabetes combo of A1C under 8, nephropathy, blood pressure under 140/90, making sure that statins are on board for patients who are cardiac patients or for patients who have diabetes. And we focus on medication adherence for our adult patients who are prescribed an ACE, ARB, or a direct renin inhibitor, statin, or oral diabetes medications. And now let's talk a little bit about population health management and how to implement, as this is one of the key ways pharmacists can really impact value-based care. So the first step in any practice-based population health management intervention or model is to identify a care gap. And this is typically done by identifying care gaps within a practice or provider level. Gaps in care could be determined through patient care experiences or changes in guidelines or recommendations or quality metrics. And an example of this, again, could be any patient with type 2 diabetes who has an A1C above 8% or 9% or a recent hospital discharge with a readmit risk of greater than 50%. So once the gap is identified, we do need to define the population, and we can define the population by some sort of a demographic or disease state or high risk medication. And then we need to do risk stratification, and risk stratification may be done to make the intervention manageable with the resources that we have available. Or it may be done to increase the impact of the intervention in order to justify the resources going into the intervention. Next, need to think about how to implement this intervention. It needs to be proactive, targeted intervention based on evidence-based guidelines. For example, which guidelines are we going to utilize? We need to think about workflows. How are we going to do this? Who will do the patient outreach? Will this be an office visit, Zoom, phone? Typically, population health management is done outside of an office visit, but it can be done via direct patient care as well. And then engagement of patients needs to take place, and this can be a little tricky because many times patients get a phone call from us and they say, why are you calling? You're not my PCP. I don't know who you are. Why are you trying to start me on a statin? I don't know what that is. So we need to have a clear plan on how to engage patients. And some things that we have done is we've sent letters to patients about these initiatives prior to the call or the visit to describe this process or what we're doing. And lastly, you'll need to measure and track your outcomes. So any patients that you call or outreach to or interventions that you make should be tracked. All right, so here's an example of a population health management initiative we just launched this year. It's called One Stop Shop. So what we did is first we identified the care gap, which are patients with diabetes without labs done in the past year. And next we identified our population of patients. We worked with our quality department to give us a list of patients who are in this care gap. And we received basically a report from the quality department of all diabetes patients without labs in the last year, such as A1C, blood pressure, UACR, and an eye exam. Next, we defined our population. So any patient with a quality goal of A1C under 8% that has commercial HMO plus PPO or HMO or PPO, Medi-Cal insurance, or A1C under 9% if they have Medicare. And of course, these are quality goals. We implemented the intervention with the help of quality department. So we utilized point of care testing for A1C, UACR, and we were trained to do retinal eye exams. And then for any patients with an elevated blood pressure or A1C, this would result in an automatic referral to a pharmacist for management. Quality department is helping us engage patients by outreaching and scheduling and explaining our services to patients. They also mail out flyers. And of course, we track all of our interventions, such as number of patients seen, number of each lab done, number of referrals made to the pharmacist. Okay, so how do we track and measure outcomes at Providence? So in 2019, we actually started using a data analytics platform called TABLEAU. This is a very powerful tool that helps us track outcomes. We use TABLEAU to collect data on operational metrics like number of patients seen, and we could look at this by pharmacist, by site. We could take a look at the number of referrals, number of patient outreaches, visit types. We can also look at quality metrics. So how many patients met the quality metrics of that A1C under 8 or 9%, blood pressure under 140/90 after the clinical pharmacist saw the patient, and how long did it take to get there? So like how many visits? We do have interventions tied to cost savings with the help of Blue Shield, our ACO partner. And in each patient encounter, we select all of our interventions during the patient visit, and then each intervention has a cost savings tied to it. So we do track those too. We track number of interventions, types of interventions, and cost savings. And of course, we do track clinical metrics too. So how many patients reach the blood pressure of under 130/80 or A1C under 7%. This is an example or a screenshot of what our diabetes TABLEAU tab looks like. We have a very similar one for hypertension or blood pressure. And as you can see on the left-hand side, we have two different pharmacy departments. Care RX is our Southern California department. Eureka RX is in red, and they are Northern California department. And so we could look A1C pre-pharmacy and post-pharmacy. We have total number of patients, average A1C, pre and post, and then the change in A1C. We can filter on the right-hand side. We could filter by date, program name, by business line, health plan. So this is pretty powerful to utilize to present our data to our administration. And this is what I was mentioning earlier on about tracking our interventions within our patient notes. So each patient note, every time we see a patient and an encounter, we pull this in and we click an intervention of what we have done. And some of these interventions on the back end have a cost savings attached to them. Some of them don't, some of them are just zero. And so, but things like therapeutic interchange and MedRec, they do have cost savings associated with them. So we click on them and they get captured during each visit. And then this is captured on the back end in Tableau. And so with this, I'm going to have Amy from Michigan Medicine take over and talk a little bit about her practice site.
Hey, Jelena, thank you so much. Great presentation. So Amy Thompson with Michigan Medicine. So I'll describe a little bit about our practice site and what we're doing to help improve quality care here at our institution. So Michigan Medicine is part of a large multi-organization ACU, and we have several PCMH-based clinics within our institution. Next slide. We have a total of 14 primary care PCMH-based clinics, and we have 14 pharmacists embedded within these clinics. It's a total of 5.7 FTE in all. Several of us have split appointments with our College of Pharmacy, similar to the model that Jelena was describing. We also have 2 PGY2 ambulatory care residents within our team to help us provide services. So this all started with one pharmacist at one site doing proactive identification of patients, and we've now grown to 14 pharmacists in all 14 clinics on a pure referral-based system. While we're embedded in each clinic, we're not there every day of the week. The time really depends on the volume and the need of the individual clinics. So typically 1 to 3 days per PCMH site. Through these clinics, we work off of a collaborative practice agreement to provide chronic disease state management and comprehensive medication reviews. In addition to this pharmacist effort, we also have a large centralized transitions of care program that we really are targeting patients post-discharge. Typically, we're trying to hit that 3 to 5 day mark by doing comprehensive medication review calls and trying to prevent those hospital readmissions. So we have 5 pharmacists in this space, which is the equivalent of 1.6 FTE focusing on those calls. Next slide, please. Within our institution, the clinical pharmacists are actually part of a larger team that are focused on improving the quality of care. So we're referred to as the Care Connect team. And so this team includes the clinical pharmacy specialists, social workers, registered dietitians, nurse care navigators, and panel managers. The panel managers tend to be medical assistants who work centrally within our department to help do proactive outreach to close gaps in care. So they might be reaching out to patients that are overdue for colonoscopy, A1Cs, lipid panels, or they just haven't been seen in some time by their provider. And so they're trying to capture those patients and get them reconnected with the care. We also work very closely with our quality department. In fact, we report up through the Associate Chief Clinical Officer for Quality and Care Innovations, Haimi Cho, who is a pharmacist who was previously in my role within our institution. We're fortunate to have several project managers that work with us, so they help us with implementing workflows and doing assessment of services. And we work very closely with leadership, and this is really important when we think about identifying focus measures that we're going to work on from year to year. So this past year, we spent a lot of time and effort focusing on blood pressure control, A1C control, and care management utilization within our Care Connect team. Next slide, please. As far as practice sustainability and utilization, so the embedded pharmacists are funded through the clinics. We have a utilization goal of pharmacists having 6 patient encounters per half day. We also have additional effort for several of our sites. 6 sites pay for additional time to focus specifically on quality measures. And so in those clinics, the pharmacists serve as the lead for quality improvement. And so they're not always focusing on things that pharmacists have a direct impact on. So for example, one of my team members has recently been working on improving the capture rate of urine drug screens and controlled substance agreements. So it's a lot of workflow development as well as things like blood pressure control and A1C improvement. We do bill for all of our visits, and we're utilize care management codes and bill for face-to-face video and telephone encounters. Next slide. So this is a snapshot from one of our Tableau dashboards where we're looking at utilization across the care management team. So you can see of the clinical pharmacist here in the middle, we're aiming for 6 visits per half day. Some of our other care managers, we're ramping them up to hit that same target. But this information is readily available to us and updated monthly, so we can quickly share feedback with our teams and work with the individual team members to try to improve efficiency and make sure that we're capturing as many patients as we can. Next slide, please. This slide is really depicting like a snapshot of patients monitored by the clinical pharmacist within our institution. And as you can see, we saw an improvement of A1C control. So the more poorly controlled the A1C, the bigger the impact the clinical pharmacist had. Additionally, on the next slide, we can see other focus measures that we have tracked and have shown improvement on. So the darker blue indicates patients who had clinical pharmacists involved in their care versus patients just followed by their providers. And as you can see, the pharmacists, when involved in care, had a more positive impact and were more successful in closing gaps in care in patients with type 2 diabetes. Next slide. And I'm sure everybody has experienced the impact of COVID over the past couple of years, but what we saw here at Michigan Medicine was that our quality measures really plummeted. It also completely changed our approach to care. And so we went from having all pharmacists physically on site at our PCMH clinics to now half of those pharmacists are completely remote still at this point in time. Some of that's due to space and social distancing requirements within the clinic itself. Others, it's because the pharmacist has been more productive and it's more efficient working remotely. And so my opinion has been, if it's not broke, we don't need to fix it. And so we're going to continue with a remote mechanism for those pharmacists at those particular sites. We have a handful of sites that are hybrid. So the pharmacist might be physically on site to do like blood pressure assessments one day of the week, but the rest is virtual. And then we have three clinics that are completely on site at this time. And so for the foreseeable future, we don't anticipate this changing because it's working successfully. Next slide. This is an example of our blood pressure control through COVID. So the March timeline here is actually from March of 21. We saw our biggest, our lowest point of blood pressure control was actually in February of 2021, when we were right at about 60%. And as you can see, we've slowly been like chipping away at improving this value over time. Our goal is really to hit that 74th% mark. And as of April of this year, we're finally at 69% across the whole medical group. So this includes primary and specialty care areas. Next slide. We've done everything that we can to try to capture as many patients as possible to still provide care even through the pandemic. And so at the onset of the pandemic, when most of our primary care sites went completely virtual, except for urgent care needs, we had to think quickly and find out, try to think of a mechanism to capture these patients and provide care to people with uncontrolled blood pressure. And so we implemented a drive-through blood pressure clinic. This was staffed by a clinical pharmacist and 2 medical assistants. The medical assistant would go to the patient's car, check the blood pressure, and then the pharmacist would conduct a phone visit with the patient, make recommendations to therapy, and set follow-up. This was so successful during the first 3 months of the pandemic that we stuck with a centralized model, and we then developed a walk-in blood pressure service. So we have a central location where any of our primary care and specialty sites, such as cardiology, nephrology, endocrine, can refer patients for follow-up blood pressure. We have now developed a centralized collaborative practice agreement so that pharmacist is able to titrate meds for all of those patients and work towards improving those blood pressure goals. We've also tried to leverage technology within our EHR as much as possible when it comes to quality measures. And so I'll walk through a couple of examples of that, and then also worked on our community partnerships to help have an impact here as well. Thank you, Jelena. Next slide. So one of the things that we noticed is that when patients came in with an elevated blood pressure, oftentimes there was nothing really done and there was no follow-up within the next 3 months for those particular patients. So we were trying to find a way to prevent people from falling through the cracks and having a quicker follow-up for their blood pressure. So we worked to develop a best practice alert, or a BPA, that would fire when a patient has an elevated blood pressure. So essentially what happens when the MA rooms the patient, the blood pressure is over 140 over 90, this first screenshot pops up and says, you know, the blood pressure is elevated, dismiss this, wait 5 minutes, recheck the blood pressure. If on the second check, the blood pressure is still elevated at greater than 140 over 90, then it prompts to open up this smart set. And when the smart set is opened up, you'll notice on the bottom slide here, it says that the patient should have follow-up with the clinical pharmacist within 2 to 4 weeks. So it automatically populates and order everything that the physician needs. They just need to sign it. Advance for me, Jelena. And so we even built it so that checkout notes were filled in for the provider as well. So when the patient went to check out, the scheduling team knew exactly what to do and how to schedule that patient for follow-up with the clinical pharmacist. Next slide. The other thing that we worked towards, especially once HEDIS recognized home blood pressure for quality measures, is we worked quickly with our electronic medical record to develop a way to quickly capture those home blood pressures. And so we embedded home blood pressure sections within telephone, video visits, and portal messages, so we could quickly and easily capture those values. You'll notice here on this screenshot that you can see where you can enter the blood pressure, and then below that you see that there's the blood pressure value entered has been adjusted to account for home blood pressure validation variance. We added this in because we took this as an opportunity to really educate everybody within the health system on the importance of blood pressure cuff validation and having a true understanding of what that home blood pressure reading means. Next slide. So here's an example of what that looks like. So if a patient were to come into clinic with their home blood pressure cuff, we could check it compared to our in-clinic cuff and then document those differences. So we could put in, was it an arm versus a wrist cuff? What was the difference in systolic and diastolic? Was it higher or lower? And then this feeds into a flow sheet, so it's easily accessible. And anybody who's providing care for this patient can quickly see the difference in that home cuff versus a typical clinic cuff and have a better understanding of what that home reading means. Next slide. We've also partnered with Meyer Pharmacy, which is a regional grocery chain here in Michigan. This started back in 2016 with 3 sites in the Ann Arbor area, but it's now grown to 5 sites. We offer 40 patient visits a week across those 5 sites. We have seven pharmacists that have trained with the PCMH embedded pharmacists, so they're familiar with how we run our patient visits. They have access to our electronic medical record. They're able to document their interactions with the patient. They are not under a collaborative practice agreement to adjust medications. However, they are able to pend recommendations for changing meds, lab orders for follow-up, and route that to the PCP. They're also able to schedule follow-up appointments with themselves to follow up on any adjustments that are made. And they're also able to bill the same way we do within our embedded pharmacy team. Next slide. So now's the time when we're going to open up the breakout rooms. And so during this first session, we'd like to take a few minutes for you all to introduce yourselves, talk about your current practice setting, where you are, do you have experience with value-based care? And then also start to describe your experience with value-based care and how pharmacists can play a role in this setting. If you are involved in the implementation of pharmacist involvement in value-based care, what did this look like? And how does your site measure pharmacist outcomes and sustainability? So we'll open up the breakout rooms. Jelena and I will hop in and out of a few of the breakout rooms, and then we'll come back together for a debrief. Had an opportunity to have some great conversations within your breakout rooms. I was only able to make it into one, but it was a really good Really good conversation. And so at this time, I'd like to open it up if you'd like to unmute, or you can drop comments in the chat. If anybody has anything they would like to share from their breakout rooms, like what they learned, what they're doing, anything like that.
Hey, I'll go. So my name is Meredith. We talked about ways to maybe expand our reach, that we're all a little short-staffed or understaffed. And so we talked about ways to use learners or pharmacy residents to expand some of what we're doing in the population health areas. And then we talked about potentially utilizing pharmacy technicians so that they could practice at the top of their license and then refer on to pharmacists. And last we talked about the most difficult piece was collecting data for our dashboards to show what it is that we're doing to make a case to then get more FTEs and continue on our services.
Thank you, Meredith. Yeah, the data collection piece can definitely be a struggle. I know a lot of people here are like on the Epic system. There's a ton of data in there. The challenge is finding out who has access to it and how to get it without having to do it manually, which I know is time consuming. Thank you.
So I'll just add on to that, to what Amy just said. So back when we started in 2017 at my site, I collected all data manually and I just did it for 6 months. And then I just presented that 6 months of data to our leadership team. And that just opened up like a lot of potential for, you know, hiring other FTEs. But yes, we also struggle with IT and getting that data from Epic. Sometimes it can take months or longer because we're always at like the bottom of their list.
Anybody else like to share?
Yeah, I'll share. So in our group, we talked a lot about our similarities when it comes to the types of measures and clinical services that we provide. We talked about, you know, our experiences with HEDIS measures and those Medicare Advantage measures, as well as looking at our contracts based upon our payers, and also having relationships between managed care as well as ambulatory care services to provide population health management, which I thought was really interesting. And we also discussed our challenges when it comes to how our ACOs are set up. So a few of us, myself included, work within ACOs that have employed physician groups as well as independent practitioners. And so we were just discussing that common ground and some of the things that we're looking at doing on our individual ACOs to increase our presence, but also increase our accessibility to the electronic medical records.
Thank you for sharing, Kristen.
Just to add to what everybody else has said, within our group, we actually had a pretty diverse group. A lot of us share the common theme of working within a multidisciplinary group, which I think is great, and learning, you know, from our other care managers about how they are implementing value-based care. I think one thing we've talked about was definitely utilizing like residents or other learners to help to collect some of that data and really show some of our outcomes for those of us who don't have access to that data or more sophisticated systems. I think something else that also came about, which I thought was a good, you know, really important thing to think about, was one of our participants mentioned like actually sharing patient stories with like leadership and, you know, higher level people. And I think just, you know, walking them through what we do. And I know starting like when I first started, that was actually a big thing. Like, so really, what do you actually do? And I think once you share like some of those patient stories, I think it hits home with some of the providers. And, you know, they start to recognize, because I've realized in my own role that like once the providers are on board with it, they can basically sell you to leadership and upper management. And so I think that's just another strategy to use when trying to implement like value-based care models in our settings.
Thank you so much, Nada. I mean, I think you hit the nail on the head there. So with everything you said, so thank you for that feedback.
Great.
Okay. Right. So we'll continue on with another short presentation on emerging opportunities. So let me share my screen, and then we'll do another breakout session It'll be a shorter one, about 10 minutes. Okay, so in this one, in this portion of our presentation, we're going to talk about emerging opportunities for pharmacists. And really, I wanted to talk about just leadership. So we are all leaders in one way, shape, or form. Our students are leaders, our residents are leaders, pharmacy technicians are leaders. And so I think we really need to take that and just step in the right direction. So basically, move forward with our leadership, right? Show our leadership skills. We should develop and implement documentation systems to capture pharmacy impact and value. And I think that's something that most of us have been trying to do, and many of us have struggled with, is showing that impact and value. How do we do that? How do we capture and get that data? My other recommendation would be to prioritize entrepreneurial skill development to help better meet the needs of patients through innovative programs. So again, I think a lot of us do work in that chronic disease management space and population health, but we need to be thinking about innovative programs like maybe deprescribing initiatives, maybe AWVs. There are so many other programs that pharmacists can be involved in. As pharmacists, we should be seeking leadership roles outside of traditional pharmacy departments. Again, that's just to move our profession forward, to show our impact and value. Other emerging opportunities is to develop pharmacy-specific measures to better document patient outcomes with pharmacist services. So have a pharmacy department and our own specific measures and our own specific, for us, it's just our own TABLEAU, and maybe even have like a dedicated IT person to our department. We don't have that currently, but it would be nice to have something like that. And lastly, implement procedures to help diversify the pharmacy workforce. So I think some of you have already mentioned this. So utilize our students, residents, pharmacy technicians, and other pharmacists to help us meet some of these quality metrics, expand the delivery of value-based care in not just ambulatory care settings, but really just anywhere throughout our pharmacy profession.
And I mean, I really need to echo a lot of what Jelena just said. Those are all very important points. And so what my mentors always said to me is like ensuring that pharmacy has a seat at the table, because if you're not at the table, you're on the menu. And so being at the table and trying to be parts of those conversations are important. And I think, you know, Nada hit the nail on the head about incorporating the patient experience into conversations with leadership helps get you that seat at the table when you're able to share data, but then also tie it to that patient experience. It's a lot easier to tell the story, and people tend to connect with that. And so I'm glad that that was brought up in the conversation. Looking for opportunities to be involved in things such as like quality team meetings. That could be at the end of individual clinic level. So like I mentioned, we have 6 clinics where the pharmacists actually run the quality work. And so they're the lead of those quality team meetings with a physician co-chair. But then there's also opportunities to grow and be involved at a higher level, even through the institution. And so again, that's having that seat at the table so that you could have an input and impact on things that you're going to focus on. The other big piece is, you know, really essentially what we were talking about in that debrief is like understanding the data and who has it and how to get it. I'm very fortunate at Michigan Medicine. We have a great quality analytics team, and all the data that I used to collect manually to show to leadership is now, you know, at my fingertips. And so I'm very thankful for that. And so this is just like a snapshot of one of our TABLEAU dashboards where I can filter it down to the clinic level. I can filter it down to the individual provider to identify, you know, all the patients on Dr. Smith's panel who have an A1C greater than 8%. So I can focus on our outreach. This snapshot actually shows me like the number of patients that we need to target to get to our goal of like the 75th percentile for an A1C of less than 8%. And so having those conversations and trying to figure out where we can get this data, even if you do have to collect it manually, which I know is time consuming, showing that data to leadership definitely helps with your story and expanding the service model. Next slide. So I just wanted to give like 2 examples of how we've implemented this here. So I know I've talked a lot about the pandemic, but it's been like, obviously everybody's living through this right now, and it's been the focus of my work for the past couple of years. And I've served as the clinical champion for hypertension control within the medical group. And so always trying to think of ways to capture blood pressures on patients and follow up on patients. And so we started thinking of unique ways. So I talked about the drive-through, we had the walk-in blood pressure clinic, but we were still really struggling with that metrics. And then we started to think about other opportunities and realized we have all these patients coming in for COVID vaccines. Once we had the Shingrix vaccine again, we have patients coming in for that. And so we started with a small pilot at one of our sites of having, we could run a report of patients who had uncontrolled blood pressure. We kind of cross-reference that to patients with upcoming vaccination appointments. And we were able to ping the MA and ask them to also get a blood pressure while the patient was there. And we found, like, while it was small, we had almost an 80% capture rate of the patients we identified. So we completed 27 appointments, and we saw an improvement in blood pressure across those patients. So we've now expanded that to more clinical sites and for more vaccine administration. So this is something that will continue. We've also expanded to include A1Cs as well for patients who have a gap there. We've worked to incorporate learners into our process. And so I think I'm going to steal Jelena's idea with the elective, because I think that's a brilliant way to incorporate learners into your practice and to help the learners and also help your practice. But what I've done is I've recruited for independent study students to help us with things like our statin gap list, because I feel like that's an area that we're always trying to tackle. And so we work centrally and pull all the patients who are on that statin gap list. And we recruit 2 to 3 students, and we basically try to get them to stay with us for a few years. So the first year we recruit right after their P1 year of pharmacy school, have them scrub the data. During their P2 year, they'll do a little bit more patient outreach or provider interaction with making recommendations. And then they start to train the next students coming behind them. So it's a great way for the students to have a unique experience. They could put it on their CV. We've incorporated it as an independent study, so they get some elective credit through the class, which is really appealing to the students. And it's been really effective for our gap list. So there are several ways that you could incorporate your learners to expand your reach and what you're doing. Another thing that we have done here is that we have for our 2 PGY2 residents, we have a half day of independent practice for them. So in addition to working with preceptors in a PCMH clinic, they have a half day where they are the clinical pharmacists. They're doing patient care and working with those providers off of a collaborative practice agreement to improve the quality of care. And so that was a way to help us expand our reach as well without a significant cost to our institution. And that's been a pretty successful model. We've been doing that here since the inception of our residency program. And it's something we intend to maintain because we've received such positive feedback, both from the clinics and from the residents. Okay, so with that, go into our next breakout session, and really just 2 questions to focus on here. So what are some emerging opportunities at your practice site to help initiate or expand pharmacist-led delivery of value-based care? And the second one is, if you have learners, so this could be students or residents, how do you envision utilizing them to help deliver value-based care at your practice site? Okay. All right. Well, anybody, same thing, like anybody would like to share anything that was discussed in your debrief session? I was in room 4 and heard some great things about pharmacy technicians and students. I'd love to hear from another room.
I would love to share, and I may call on Rena to add any other comments because she had some great ideas that she brought to the group, but unfortunately we didn't have a lot to share back with her. So we talked about a few different ways that we are growing in the pharmacy services provided. So in one example provided by Rena, who works at Harborview in Washington, they have now the capability to increase their activities within depression and those specific quality measures. So historically didn't have the staffing for that in terms of pharmacist time, but with growing numbers of patients ending up on their depression list, likely due to COVID presence, seeing more opportunity there for pharmacist engagement and are looking at how to get started there. So we didn't have a ton of ideas to share with her there. And then also related to that, looking at opportunities within pharmacogenomic testing. Serena, hopefully you don't mind me bringing that to the group. I wanted to make sure if any others have experience with that or ideas to share within our team, wanted to solicit from the group, if that's okay.
That was great. Thank you.
I'm not hearing anyone jump in immediately, but now you know where Rena is thinking. So if it's something you're thinking about, maybe consider reaching out to collaborate in the future.
Great, thank you. Would anybody else like to share or have any questions since we have just a few minutes left here?
I'll share an idea actually that Shelly in our group uses with learners. So she utilizes APPE students to help patients navigate the Medicare website and understand the information provided there regarding plans and costs of different plans.
Yeah, thanks, Ashley. Yeah, we actually have our students do a telehealth visit with our patients in our chronic disease state management, well, our chronic programs during Medicare enrollment. So they walk the patient through how to use the website and mail out their printed results to them so that they're able to have more information to pick a plan for the upcoming year. And that really reduces down the number of cost-related referrals that we seem to still be getting on occasion.
Great, very cool. Thank you for sharing that. Any other questions or comments?
I can kind of quickly share something that Marie talked about at her institution, and she can chime in as well. But she said that they're going to start implementing using a risk score to see like which patients are at higher, I guess, like to prioritize like patients that we should prioritize them for outreach. So like I think they're still trying to figure out like details like what components are part of that, but probably like something like social determinants of health or their chronic disease states. So that will kind of make up that risk score and they can help target those patients better.
Yes, we talked about that, and I was saying I don't think it's quite validated for our group yet, so that would be one thing I would want to do. And really, I just learned about it the other day from our lead provider, but seeing if there's a way to incorporate that and kind of targeting those highest risk patients to either get an appointment or do some sort of outreach with those folks.
Great. I think we're at time. So thank you so much for attending today. A big thank you to all of our facilitators and Megan for running the show, helping us facilitate all this. And if you have any questions for either Amy or myself, please feel free to email us. I don't know if our email was put in our slides, but I'll share mine in the chat if you have any questions. And yeah, have a great rest of the day. Thank you.
Thank you all.
And to echo that, thank you guys for attending. If there's any feedback that you'd like to provide on the program and how it was run, we greatly appreciate that. We will be having another webinar with a similar format, depending depending on feedback at the end of the summer related to comprehensive medication management. But we appreciate your attendance and thanks for all that you guys offered to the conversation today.